I want to introduce myself. I'm Wendy Reibold. I'm the interim dean in the Rongshangshu College of Health and Human Services, which is the college in which the Department of Public Health sits on this campus. So, welcome you. It's a pleasure to see so many students, faculty, and staff. And also, most importantly today, the community partners. And it's so fun to see you guys all gathered in one room. So I'm grateful that you guys are all here. In our college, the Rongshangshu College of Health and Human Services, we are deeply committed to preparing the next generation of leaders who will serve and strengthen our communities. Public health is central to that mission. Why? Because it shapes the conditions that allow individuals and communities to thrive. It's present in the air we breathe, the water we drink, the safety of our neighborhoods, and the systems that respond in times of crisis. Here in Los Angeles, public health is not abstract. It improves the daily lives of nearly 10 million people. This evening, it's especially a significant time because it marks the launch of our academic health department partnership with the Los Angeles County Department of Public Health. The partnership reflects, let's clap for that. I'm excited about that. The partnership reflects a shared commitment to connecting education with practice, right? The thing that we all want to do as academics in a public setting. And what we want to do with this partnership is really ensure that what the students are learning in the classroom is directly linked to the work that's happening in the communities across our region. Through this collaboration, we aim to expand opportunities for our students, always a good thing. We want to strengthen our engagement in the community itself with our partners, and we want to contribute to advancing health equity in Los Angeles. It represents not just a partnership, but a shared responsibility, something that is going to require all of us to pull together to build a healthier future together. To our students, and there are many of you here, the work is really about you and for you, because soon you will be the ones leading this work. We're preparing you, right, to lead this work. We hope this partnership opens doors for you, deepens your learning, and helps you see the impact you can have in public health. I want to thank you all for being here. I want to really just praise, and I'm going to introduce him in a second, your department chair for pulling this together. It's an important moment in our history. And now I'm going to introduce him. It's now my pleasure to welcome one of our founding leaders in this academic health department partnership, Dr. Greg Stevens, your department chair, professor in the Department of Public Health.
Okay, thank you, Dean Reibold, and thank you everyone for being here tonight. It's really nice to see this room somewhat full. I was here earlier today just checking on a class and seeing how the room looked, and it was, I think, a math class. There were like 3 or 4 people in that room, and I thought, well, we got to get our act together. But it really is meaningful to be together in this space because public health is really about showing up for each other. It's about working together to make community health better. We do that together. I want to start by recognizing a few key partners in this process, not only for the event tonight, but for this collaboration, this academic health department that we're forming. I'd like to say thanks to Daniel Rizek-Bayer for leading this, along with Jocelyn Astindian and Jennifer Tsai, Lonnie Resser as well. On the Cal State LA side, we have an academic health department team that's made up of Dr. Endi Atim, Dr. Kim Kistler, Dr. Joel Wolstein, and Dr. Tony Sinai. Many of them are here tonight. I also want to acknowledge our student leaders, the Public Health Student Association, and the Environmental Justice Club, who co-sponsored this event together. They are doing incredible work on this campus this week with National Public Health Week, and also coming up with Earth Day in April. So they are busy on campus. And what's beautiful about what they do is that it reminds me every day that public health and environmental work aren't just things that you learn in the classroom. They're things that you practice and you build here on campus. So thank you to them. I also want to give a quick shout out to our Masters of Public Health students You want to raise your hands? Nice. And also our alumni. Anybody alumni? I should acknowledge that our Masters of Public Health program is only 8 years old, and yet we're ranked in the top 1/3 of master's programs in the country. That, I think, it speaks to the strength of not only the teaching and the quality of the education, but also to the quality of the students. I think it's amazing when you bring together high quality students with accessible, affordable education, and we align that with a mission, we make a big difference. So thank you, master students and alumni. That connection is really what tonight is all about: learning, leadership, and real world impact. So with that, I'm going to now switch to introducing Dr. Anish Mahajan. He is the Chief Deputy Director of the LA County Department of Public Health. It is arguably the largest health department in the nation, serving about 10 million residents. He's led clinical care teams, public health systems, and national policy. He was the CEO and Chief Medical Officer of Harbor UCLA Medical Center and worked as a White House Fellow during the Obama administration working on the Affordable Care Act. His work, I think, reflects what it means to work at the intersection of healthcare systems, public health systems, and health policy. And I'm really excited to see and learn from him tonight. So please join me in welcoming Dr. Anish Mahajan. Thank you for being here.
Good evening, everybody. It's so nice to be here. It's such a pleasure and honor for me to be here and speak with you all and to represent our department and all the communities and community partners, academic ones included, that work with us to make public health possible and to help serve our communities here in LA. I want to start by thanking the Cal State leadership, including the Dean Wendy Reinbold and Dr. Greg Stevens. Thank you for that kind introduction. It's wonderful to see everyone here in the evening, the faculty, the alumni, and of course, most importantly, the students. This lecture, I hope, this talk, and I hope we can really get into some question and answer and discussion, is really for you. You all are our future, and you will lead us and you will help us solve our hardest problems. So let me, with that, take a sip of water and find the clicker, which is here. Turn it on. I try to turn it on and off again. Maybe I can advance with the, I'll just do that way. No problem. Thank you. So we're here celebrating thanks so much, National Public Health Week. And National Public Health Week this year comes at a time that is quite challenging for public health departments and all of us who work in public health around the nation. I think, I do want to start by saying, I think we would all agree that public health is a nonpartisan issue. Unfortunately, in this current federal administration, we have seen significant threats to information and accuracy about public health, as well as resources. We've seen funding being terminated or reduced across the nation and also here in LA County for our most vulnerable populations and communities, including transgender and gender nonconforming communities, immigrants, and people with HIV and AIDS, just to name a few of the groups that have been targeted for funding reductions. These actions threaten all of our abilities to protect everyone and to protect our community and ensure that we can all thrive and have well-being. And here in LA, in Los Angeles County, as mentioned, there are 10 million residents or Angelinos of Los Angeles across 88 cities, which is why our public health department is among the largest, because we have such a large community and a community of communities here in LA. So the stakes are high for sustaining public health. Oops. So I'm gonna start with a question, and I would invite audience members to shout it out. There are really no right answers here, but what is public health? I hear everything. What else? Inclusivity. Don't be shy. Wellness and prosperity. Herd immunity. I like that one. Equity. Health. Justice. Opportunity. You guys are learning well. I can see why you're among the best public health departments in the nation. I'm going to give you what the CDC's definition is. They say it's the science of protecting and improving the health of people and their communities. Public health focuses on preventing disease, extending life expectancy, and promoting overall well-being. I think all of the answers that were given were exactly right and fit under that definition. And you know, for me, I think of public health as really the health of the entire community, the entire population. And I think of that in distinction to something that's a component of public health, which is healthcare delivery, where you think about the healthcare of an individual. Okay, next question. What is a safety net? Also, no right answers. No wrong answers, I should say. How would you define the safety net? What do we mean by that when we say that we need to protect and sustain the safety net? Thoughts? Something that's reliable. It's a net. It should be there for you if you need it. Insurance. Definitely a key component of how people think about what the safety net is. What else? Standards of care. So there should be a standard of care that everyone can enjoy. Affordable care, and the idea that everyone should have access to care when they need it. So I'm going to give the official definition, or one of the official definitions of the safety net. The Institute of Medicine or the Academy of Medicine describes it as those providers that organize and deliver a significant level of health care and other needed services to the uninsured, those who rely on Medicaid, which is a type of public insurance, and other vulnerable populations. And key components of the safety net, when we talk about the safety net in Los Angeles, we're talking about things like federally qualified health centers, public hospitals. We're talking about health systems, local and state health departments like ours, and all of the community-based organizations that are supporting vulnerable communities and populations who rely on public insurance or who may not have insurance, and who may have additional needs. The safety net, of course, plays a critical role in addressing and reducing health disparities, preventing disease outbreaks, providing essential services during crises like wildfires, for example, or pandemics, and supporting overall population health. My next question, what are health disparities? Someone give me an example of a health disparity? Can you repeat that? Difference in life expectancy based on zip code, yep. I'm going to tell you. I'm sorry? Okay, well, we'll talk about it again. Repetition is the way to learn, and that's good. So, you know, I'll talk about one health disparity example, and then I'll give the official definition. But one of the examples that struck me hardest when I was training in medical school, or when I was training in residency here in Los Angeles, you know, I would get to go, and I trained at UCLA Medical Center in Westwood, and there was a certain kind of patient population there, mostly people who had insurance, and had, you know, could go to the doctor when they needed to, could get the medications they needed. But then sometimes I'd rotate to the public hospitals and spend a month, for example, at All of You Medical Center in Sylmar, which is one of the hospitals that's considered the safety net, serves people who are uninsured, people who rely on Medicaid or Medi-Cal insurance here in California. And what we saw there, what I saw there, were patients with diabetes coming in with significant foot ulcers, for example, and sometimes needing amputations. And then looking at a study that was put out around the time I was in residency, there was a study that showed that here in LA County, we had among the highest rates in the nation of avoidable leg amputations or foot amputations. What does that mean? So people with diabetes who, if they had access to primary care, they had regular access to the preventative care when you have diabetes, to take care of your blood sugar level, to take care of a foot ulcer if you start to develop one before it gets worse and needs an amputation. There's a way to prevent it. It's supposed to be preventable. But because of a healthcare disparity of access to diabetic care in Los Angeles County, we had in the 2010s among the highest rates of avoidable amputations. That's an example of a healthcare disparity. And so what's the definition of a health disparity? It's differences in health outcomes between segments of the population, often driven by social, economic, and environmental disadvantages. These are usually systemic disadvantages. That means they're not random, they're systemic, and they're usually unequal and we heard someone say justice, or unjust. That's what a health disparity is. And so these are some key concepts that I think I want you to be thinking about as we talk about what we think is the state of public health further on later as we go through this evening here. This is a cartoon of the American healthcare system. I'm going to say a few words about my journey to public health. I'm a physician, an internist, and I was a primary care doctor. And I started in healthcare, which is symbolized by that. I'm not sure if it looks like blood coming out of that IV bag there. I started in healthcare, and I worked, as I mentioned, in residency at UCLA, and then I joined the faculty there, but continued to practice in healthcare. But I was struck by what I was seeing. I was struck by disparities. I felt like, gosh, there's got to be something more we need to be able to do to make the healthcare system work better. We can't accept that there's like huge swaths of people based on their race or based on where they live, their zip code, or based on their income level, having these avoidable complications. And so, I was in healthcare, and healthcare is kind of a mess, as you can tell from this diagram here. Healthcare access is hard, but, and so I wanted to understand that more. So I was really fortunate to go here. Does anyone know what that gray building is? Or what those white columns are in front of the gray building? You wouldn't really know unless you were there. That's right. That's the White House. That's the West Wing right there. And that's the Eisenhower Executive Office Building. There's a big gray, kind of looks like a layer cake building that's next to the White House. It'll probably be sort of way overshadowed now by the new ballroom that's being built. But it's a pretty big building too. And it houses the offices of lots of different departments of the federal government. And I got to work in that gray building while I was in Washington, D.C. and in President Obama's administration in 2009 and 2010, when we were talking about trying to create something called the Affordable Care Act, what became called the Affordable Care Act. But at the time, we called it healthcare reform. And at that time, back in those years, there were more than 45 million people in the country who didn't have health insurance. They just didn't have the basic health insurance to be able to regularly have a doctor or a provider and to get the care they needed. We also had the problem that healthcare costs so much and gobbles up all the money. And so the Affordable Care Act ended up becoming law and passed to address those kinds of concerns. Can we expand insurance access to people who are low income who don't have it? And that's what it did. It was called Medicaid expansion, right? It was the expansion of eligibility for insurance, for public insurance to people who are low income, who weren't previously eligible. And it included some other measures to try to improve the quality of care and reduce the cost of care And that was very exciting. And for me to be there, to see it pass, and to sort of have this hope that, okay, we're going to address some of the problems of the healthcare system was very exciting for me. And it led me back to LA after Washington, D.C. And I came back to LA County and joined the LA County Department of Health Services, which is our sister department to our Department of Public Health. It's a county-run health department that runs the public hospitals and a bunch of clinics that are run by the county and some other units that help do the healthcare delivery in the safety net. And one of those hospitals is Harbor UCLA Medical Center, and that's where I worked for a lot of my time when I was at DHS. And there, even with Medicaid expansion, which was great, we suddenly had way many more patients who had insurance, and we worked really hard to make sure every patient would have a provider, a regular either doctor or nurse practitioner who could be their doctor. Not a different one every time they went, but the same one. I served in primary care there. I saw patients half a day a week at Harbor UCLA as a primary care doctor. And it was wonderful because now people who didn't have insurance, didn't have a usual doctor, now we're getting access to that because of Medicaid expansion. And there were a lot of good things coming out of that. We were trying to address that example I gave you, that people with diabetes, we're trying to prevent them from getting to the point where they needed to have, where they got a severe complication, needing an amputation, for example, or going blind when that's avoidable. We were working on all of that. But the truth of it was, while I was there, was that, even though we had these new options for people, people's lives are hard. They're dealing with lots of social challenges, and it's hard. And so a third of patients who were eligible for Medicaid here in LA County, who might have even signed up, couldn't come to the doctor on time. They're working, they don't get sick leave. So if they skip work to go to see the doctor, that means that day they're not going to get paid, or they might even worse, lose their job. And so there was a large segment of the people we were trying to serve who were not benefiting from the healthcare system or having trouble getting to it. And it was another moment for me to say, gosh, this isn't going to really solve the problem. This isn't really going to move the needle on those health disparities that we worry about. We worry that, and we should be worried that Black and Latino groups in Los Angeles have the highest rates of stroke, have the highest rates of high blood pressure, and diabetes. Even though we can maybe give them health insurance and we can give them a choice to come to healthcare, it wasn't going to help move the needle on that. And that's what led me to really wanting to understand and move upstream from healthcare delivery to the greater set of things that determine a person's health and a community's health and a community's well-being. And so my journey took me from being at the bedside in primary care and then the hospital, seeing that even giving healthcare access to everyone wasn't going to be enough to help everyone thrive. It led me to this amazing opportunity that I felt so grateful to have, which was to come to public health. And public health takes a step upstream to say, what are all of the determinants that impact the well-being and health of groups, with a specific focus on groups that are vulnerable, that may be subject to various kinds of disparities. So what is public health now in 2026? What do we mean when we say public health? I'm going to briefly mention what our department's mission is, but then really try to talk about examples about what public health is doing in 2026 and give you specific examples about what that looks like from programs in our department and what it looks like on the ground. I think the dean said it so well that, it's so important for practice of public health to be informed, not only by those of us who work in the health department, but also by our community partners, some of those who are in the audience, our academic partners, and so many others. So for us, the DPH mission is to advance the conditions that support optimal health and well-being for all. That's our mission. And so in 2026, from a big picture standpoint, there's a lot of different things public health is and does, but I would say that increasingly public health is moving toward addressing and wanting to address the social determinants of health, to do it in a community engaged way, and to really meet people and communities where they are. Not just have to wait for them to come to the clinic or the hospital or to come to a place. And that's what I think are some of the things I'd like to touch on today and give you some examples about. So some of the social determinants are in that circle there. These are the various things that impact a person's well-being or community's well-being and their health. It's not going to be surprising, right? Healthcare access, we've just talked about, but education, your neighborhood and what it looks like. Is it safe? Do you have room to exercise? Is there a place to go for a walk that you can go for a walk in the evening? Your social and community supports, your economic stability. These are the social determinants. And, I'm going to just mention a few of the domains just to, there's many domains with which public health intervenes, but I'm going to mention a few today. Some examples from clinical care and prevention, from disease outbreak and response, in the policy arena, some policy work we're doing, and environmental and climate health. So in clinical care and prevention is a key component of public health, right? And so I'm going to just mention our substance use and prevention control program. This program provides a full spectrum of prevention, treatment, and recovery services to reduce the impact of substance abuse and use across LA County. We in public health support a network of behavioral health providers, as they're called, who provide all kinds of services, both prevention and treatment related to substance use disorders, and provide recovery supports. The prevention side of our substance use and prevention department implements primary prevention plans using evidence-based strategies, everything from reducing underage and binge drinking to addressing misuse of prescription medications. And we try to do that and try to have our partners do that in a community partnered way so that it can be optimally matched with what the community wants to receive and how they want to receive that information. The second bullet is about our community public health teams. This is a relatively new initiative that was launched about 2 years ago here in LA County. And it involves our department partnering with a federally qualified health center and a community-based organization in a three-way partnership that's place-specific. So it's really targeted in certain zip codes and neighborhoods where we know they have the greatest disparities. And what we've tried to do is recruit one CBO, community-based organization, one FQHC, federally qualified health center, and our staff to work together to build a real relationship with the community. The idea being the CBO is known to the community, the FQHC is in the community, and it literally is going door to door over 4 years, meeting people, surveying their needs, and trying to connect them to services and build that relationship, hear what they need and how do we meet them. This is an innovative strategy here in the United States. It's been used in other places like Costa Rica, and that's another example of where public health is here in 2026. We also have our home visiting program with our public health nursing, visiting and supporting families after birth and providing a whole host of services. And so, I give these as some of the examples where, we hope to see graduates of your program interested in either partnering with us or coming to work with us and supporting us. I think there's a lot of opportunities across our programs for you to participate and volunteer or intern, and we welcome that. And you will bring as much as you will get out of it for us. So you will serve the community by being there, and so we would encourage you to consider things like that. Disease outbreak and response. So, we in LA County, we're like the epicenter of travel, right? We have major events here. We have the World Cup coming up in a couple of months. We have the Olympics. We often have the Super Bowl, but we also have all kinds of other stuff happening. We got people coming in and out of our county all the time. And it's what makes it wonderful. But it also brings with it some risks related to infectious diseases, right? Things like measles, bird flu, tuberculosis. And so in public health, one of our units is engaged in disease outbreak and response. They're providing surveillance, trying to find out when, in an early warning way, when there are certain kinds of infections that pop up, and then making sure that we control them. For example, the measles, right? Measles, you've probably read about measles. Unfortunately, measles is making a strong comeback in our country, which is sad and very concerning because it's a deadly virus. And so if there's a measles case, that's diagnosed in LA County, it's required by law that whichever clinic or hospital diagnoses it, they have to inform us in public health right away. And they have to do that because we in public health then have to go and find all the people that might have come in contact with that person who had measles. That's called contact tracing. And we have to make sure that those people know what signs and symptoms to look for in themselves, make sure that they've had their vaccination if they haven't, check them for their titers, right? And try to control and contain the situation. If somebody has active measles and they enter a room like this, and if there's any individual in a room like this who's going to be exposed to someone with active measles and they are unvaccinated, or their vaccination or they're immunosuppressed and the vaccination they had is not going to help protect them, they have a 90% chance of getting measles. That's a huge risk. And in measles is deadly especially for people who are immunosuppressed and for young people and children. In the 1990s, early 90s, we had a really big measles outbreak in the nation. More than 120 children lost their lives. American children lost their lives. Most of them were Black or brown. The reason was they didn't have access to vaccination. It wasn't because their families didn't want their kids to be vaccinated. They just simply didn't have access to vaccination. It led the Congress to pass something called the Vaccines for Children program, which was intended to improve the access of vaccination to people who traditionally didn't have insurance or who were in the safety net. And so this is how serious this is. And, I think there's a whole nother discussion we can have about some of the misinformation coming around about vaccinations and the risk that puts all of us at. But that is why we're starting to see more measles. Okay, we can say a lot more about that, but I'm going to move on to the policy area, medical debt. Medical debt is a significant problem in this country. It's the #1 reason of personal bankruptcy in America. 1 in 9 Angelenos has thousands of dollars of medical debt, 1 in 9. And the amount of medical debt for the Angelenos is more than $2.9 billion. And medical debt is not just a financial issue. If you have medical debt, you're really worried. It makes you not want to go see the doctor or have your family member go see the doctor the next time they need to. And that just makes things worse. It means that people are avoiding basic necessities like paying for food because they gotta pay for their medical debt. A lot of people go into medical debt, put it on their credit card. And then the credit card rates are so high that they can't afford basic stuff for them and their family. So this is a very serious problem. And so in public health, we have a unit that worked to create a coalition of hospitals and health plans to say, how do we make sure that when patients end up in the hospital, that they don't end up with a big bill that they shouldn't get? Because there are laws in the state that say that if you are below a certain income, even if you're uninsured and if you can't pay, the hospital is supposed to give you charity care, financial assistance it's called. But we also know from the data that, hospitals, even though they try, they often don't connect the dots with the person who deserves financial assistance. So there's a lot of people who don't get the financial assistance they deserve and need. And so what we've done is create a coalition where we've had all the hospitals come together and say, let's talk about what's the best way, what's the best practice when a patient ends up in the ER who needs who might not be able to pay their bills or doesn't have insurance. What's the best way to make sure that they can get their financial assistance they need? So we're creating these model best practices. But we also did something, the first in the nation here in LA. The County Board of Supervisors passed an ordinance that requires hospitals to report to us in the public health department For each individual, they report to debt collections. So that's somebody who can't pay their bill. They got a bill. They probably didn't need to get the bill because they probably should have gotten financial assistance. They're unable to pay the bill. They report that person to debt collection, and the debt collectors go after them and ruin their credit rating, right? So now it's now a requirement for hospitals to tell us when they report any single individual to debt collection. Why? Because we're going to go and check and make sure, did that patient was that patient actually eligible for financial assistance, and we weren't able to successfully get that to them. And so that's an example of an intervention in the policy way of the public health world to try to address that problem. I'm going to go a little bit quicker here. I have till what time? 5 more minutes? Okay, yeah, I'm going to move a little quicker here. Just mention environmental and climate health. We in public health need to do much more in environmental health. And this is an area, if you're a student and you're interested in the environmental determinants of public health, this is an area of increasing need. And our hope is to increasingly grow our programs in environmental health. So what do we mean by environmental health? We mean things like, for example, we had the wildfires here in Altadena and Palisades. There was a lot of contamination of the soil with chemicals that burnt. And so, understanding those risks, how to mitigate them, we need more and more public health experts to help us with that. How do we deal with heat? The planet is heating. And how do we ensure the public understands how to protect themselves from heat is another major public health issue. And then all of the other issues related to oil wells and the other kinds of environmental toxins increasingly impact health and is a growth area in public health. So overall, in public health, it's a lot of things. Someone said everything in the beginning of this meeting, and that's right. But increasingly, we really need to look at the social determinants of health and really try to figure out how we address that. I want to mention that, what I started with, that there are lots of, challenges right at this moment in these year, hopefully not for many more years, of funding for public health. And we can talk more about that afterwards. I don't want to sort of belabor this one, but I do want to just say that, we in public health have already had a $50 million cut in our funding. It led us to have to close our clinical services in 7 of our clinics. These are hard choices we had to make because our funding is reducing. And there's more and more risks from the new administration, from President Trump's administration, threatening to cut more and more funding. And this affects everything I've just talked about and more. And so there are things we're trying to do. We've just launched a foundation last week called the Fund for Advancing Public Health LA to try to look for other ways of generating money to support public health services. And there's something else that's that if you're a voter here in Los Angeles County, in June, first of all, I hope you'll go and vote. And on the June ballot, there's going to be a measure that the County Board of Supervisors have approved to put on the ballot. And this measure is a half-cent sales tax, meaning that half of a percent sales tax on most goods that are sold here in LA County would generate revenue for 5 years to support the healthcare safety net. This is hard. I'm not saying that I'm not advocating this. I'm just trying to educate here. Just want people to learn about it, understand it, and make your own decision about whether you want to support it. What it would do is it would raise about $1 billion annually that would go to public hospitals, public clinics, federally qualified health centers. A small portion would come to us in public health to fill the gap, because you may have read about the big, beautiful bill, the so-called big, beautiful bill, HR 1, that was passed last July 4th and signed by the president. That's changing how Medi-Cal or Medicaid is, the eligibility for it. It's going to mean more than $2.5 billion less of funding in LA County. It's going to probably mean clinics and hospitals and some of our services, more of them will have to close and end, which is why the County Board of Supervisors felt it was important to have the voters consider another way of at least partially filling that gap, and that's what this is. Finally, the academic health department. This was mentioned earlier. This is something we're very excited about. We're so delighted and excited that you all in Cal State LA are going to do this with us, are doing this at the launch today. I think you are the first in our dispatch for us to join us in an official way. We really appreciate that. There's so many benefits to the academic health department, and we can save some of that for a little bit later in the discussion. These are just some examples of what those benefits are. Collaborative research, education and training, having you join us in public health practice, and for us to learn from you and you to learn from us, and to really for the benefit of the community. I think that you all, as I started by saying, are the future. You will show us how to solve our hardest problems. And so, we are excited to have you learn more about our programs. And join us. Join us now. Join us when you graduate. We also have so many partners in LA County that we work with and fund that do public health that we can tell you about. So, in terms of, what should we do now? What can I ask you to do? I would just ask you to stay alert to what's happening with public health and how it's being supported and how it's being funded. I think that's important. Obviously, consider all of the different career paths that there are in public health. As I mentioned, think about going and talking to any of us, even if you don't have time to do an internship or volunteer, don't be shy. Email any of us from public health department. There are a bunch of us here. Talk to us for a half hour. You can ask us anything you want about what our day is like. How did we get to where we got to? What's the kind of work you get to do? I am sure every single person that you would email or cold email, you don't even need to cold email, you can email me and I'll introduce you to some people. They'll talk to you and they'll love talking to you about what it is to do public health. With that, I'm going to stop and close and say thank you again to Cal State University, to the Dean and Professor Stevens and everyone here for coming out tonight. Thank you.
All right, so thank you very much, first of all, Dr. Mahajan, for that nice introduction to kind of what public health looks like in 2026. I think many of the students in this room were already familiar with the kind of ideas of health disparities and safety net. I mean, many of them are not only studying this, but many of them are living it. And what you're saying resonates very strongly with this crowd. So thank you for that. I think that was excellent. Public health has a kind of right now a negative feeling to it. There's cuts to funding. People are talking about public health. There were kind of resurgence of measles and misinformation, and public health just kind of gets this very negative, downer kind of feeling. None of our students really want to feel that. They want to feel that they're going into a fully functional, growing, successful field. I don't expect you to have all the answers, but I do have a feeling that you have a sense of, what we could be accomplishing despite all of these challenges. So what, for example, do you see as giving you hope or giving you a sense of optimism about where public health could be going?
Yeah, thanks so much. I would say that what gives me the most hope are the people who choose to be in who choose to work for public health, not just our department, but from any vantage point, whether it's a community-based organization, an academic institution, or a health department, state or local. That's what gives me hope. And the reason I say that is we went through COVID together. I think that's partly why people are kind of sick of public health, because they were sick of COVID. They were sick of staying at home. They were saddened by all the loss that we suffered in COVID. Of course, it would have been much worse if we didn't have public health intervention, and that's the hard part for people the counterfactual is hard for people to understand. But I think just to say, it's a very difficult time in public health because the bully pulpit in Washington, D.C., frankly, doesn't understand public health and is saying the wrong things. But and they want to cut public health. The bully pulpit, I mean, the administration. But Congress, a bipartisan Congress, Republicans and Democrats, didn't vote for cutting health funding. The president wanted to cut health funding by 50%, public health funding literally by 50%. The Congress said we're going to give the entire country level funding, which basically means the same funding we gave them last year, Republicans and Democrats. So I think that the people who have the loudest megaphone right now are anti-public health, but that's not even red and blue. It's just that small segment, and they have the megaphone, they have some power. But I actually think public health is going to definitely see the other end of this, and sooner rather than later is my hope. And what gives me the most hope is that, you know, in light of all these challenges, like today we were in a meeting with your partner who works at LA Care, and we are conspiring together, the health plan, the community-based organization, the public health departments, to figure out how we do the best even in these challenges. And that's what gives me a lot of hope.
Well, thank you for that. And sitting right next between the two of us here are two of the next generation of public health leaders. This is Jocelyn Bravo. She's an undergraduate student here at Cal State LA and part of our Public Health Student Association. And this is Jhoanna Avelino. She's one of our Masters of Public Health students and also works at the Student Health Center here and was an undergrad with us. So definite future public health leader. So you're going to share the questioning here.
Thank you so much. I see a lot of friendly faces from like classmates, so I'm really glad that you guys are here supporting. I'll go ahead and introduce with the first question, if that's okay. So I have one here for many of our Cal State LA students that are ready to be the next leaders, professionals. What role can students and young professionals play in shaping the future of public health? And what skills and mindsets will they define the next generation for their public health journey?
Yes, great question. Great questions. I would say, you know, Professor Stevens said it at first, you know, about what role can they play now. It's showing up. It's showing up any which way that you can. And people have different constraints on their time, of course, and that's understandable. Showing up everything from, as I said, reaching out to us and saying, I just want to understand from you, Anish or Noel or Christina from Public Health, what you do and how do I get there, to joining us in our community engagements. Join us in our programs as interns or volunteers. I think all of that you can do now, and you will have a much bigger impact than you think. You will provide us with knowledge and insight from your life experience, from your education that we need. We need all of those voices. In terms of the skills, I think that, you know, there's many different specializations within public health, but there's some generic skills. And one of those generic skills is, you know, even if you're not going to be working as a data junkie at the computer programming data, you should understand data, how to read it, and the limitations of it. That's just a general skill that all public health fields need. And I think the other one I'm going to say is communication. Public health works best when we build mutually respectful relationships, not only between people, but between organizations. And that's like a skill you gain with experience and practice, and that's really important.
Thank you so much. As an undergrad perspective, I can't emphasize how important this information is. And just the fact that you mentioned coming together and staying together and just being part of a community. And I will pass it on to a master student, Jhoanna.
Awesome. Thank you so much. So we're a little bit curious about further issues. So how prepared is LA County for emerging public health issues? And this can be unpredictable things like a future pandemic, or even maybe predictable things like the health effects of climate change.
It's a good question, and it's a hard one to answer. I will just say we had a huge test in the wildfires. And, you know, there are things that public health did, and there are things that our partners did in public safety, the fire department, the sheriff, and all the other agencies that respond that were good. And then there were definitely shortcomings. And so I have to say that most importantly about preparedness is that it's really learning from the last event and trying to apply the lessons. And so at the moment, we're in these after action reviews to try to understand what went well and what didn't go well, and what do we need to fix for future wildfires, for example. But, I would say that overall, the COVID pandemic exposed nationally and here in California that there was not enough investment in people and systems for public health response. It's what led to the legislature saying we need to create a fund to create public health infrastructure. So this was a moment where it wasn't, we're going to give you money for HIV/AIDS treatment. We're going to give you money to build infrastructure. And what they meant by that was you need to build up your systems so that you can respond better to the public health emergencies and other things that come your way. And now, of course, memories are short. So now that money is starting to be cut a little bit, which is why we need to tell our story, which is why you all being here tonight gives me so much hope, because hopefully you will go and tell the story to your families and to your friends about why public health investment is so important.
Thank you so much for that. Dr. Stevens?
Well, we had promised that we would take questions from the audience. Just so you know, we received a ton of questions submitted during the registration process. But I want to give priority to anybody in the room. If you'd like to ask a question, what will probably happen is you'll say it, I'll repeat it, and then we'll answer it. So does anybody have a question they would like to ask? Please.
Hi, my name's Andy. My question is, what's one public health success story that doesn't get enough recognition and what's made it so effective?
Okay, this question's from Annie. We know her well in this department. And she wants to know what's one public health success story. Great.
There are so many success stories. And so I'm going to pick one that I don't know if it's the most successful or untold story, but this is going to be about something called Mpox. Mpox is a viral disease that impacts certain groups disproportionately and can be certain subtypes of Mpox can be more deadly. And so there's two major subtypes. And the Mpox outbreak that occurred last year and the year before was of the subtype that was considered less dangerous. But this past, like 3 months ago, 4 months ago now, there were 3 cases here in LA County of new cases of Mpox where the people who got, the individuals who got Mpox got really sick, nearly died, went to the ICU in the hospitals that they were in. The public health story of this is that our team used advanced techniques called genomic sequencing to first, in our lab, diagnose that these were the more dangerous subtype. And then they informed the Centers for Disease Control in Atlanta, as we're supposed to, and then use that genetic sequencing to determine whether these 3 cases were connected or not. Were these individuals that might have, do they have different strains of the virus based on the genetic sequence or not? And it's these kinds of, uses of advanced technology, both, and there's even AI now starting to be involved in this, to help us try and maximally and most rapidly determine the risks and protect people. And so it's a kind of in the weeds story, but I tell it to say that what's behind that, there's a lot of money invested in the public health lab. There's a lot of really expert lab technicians and scientists looking at the data. And then there's the people, the nurses and the community investigators who go out and meet and find all the contacts and make sure we understand it. So, that story, I ended up being in Atlanta a couple months ago for a meeting, and some of the people there were talking about what a great job in LA County they did in identifying this dangerous subtype and then figuring out its genetic sequence and then figuring out how to use that information to protect the public. So that's an example.
Let me ask you a quick follow-up. Is that translatable to another potential outbreak? Do you feel like what you learned with Mpox there is applicable?
I think that, the CDC keeps a registry of the various genetic sequences of all the viruses that are sequenced, and not every jurisdiction has the ability to do this in an advanced way. And so they'll send specimens to the CDC and then the CDC will do it. But, but that takes time and it delays the response. But I want to mention one more example about this genetic sequencing. So the World Cup is coming. It's going to be played at SoFi Stadium. And so our director has worked with the SoFi Stadium to say that we would like to hook up wastewater surveillance. So from the sewage that comes out of the SoFi, we're going to be taking, samples regularly and testing it to see if there's evidence of measles, norovirus, and other things using genetic sequencing. The idea, of course, is to say, somebody might get one of these infections, but not even be symptomatic yet, not even know they have a problem, but we'll have an early warning sign because we're testing the sewage coming out of SoFi, and then we might be able to know, oh no, we've got a hit that there might be measles. Somebody who went to SoFi on this and this date might have had measles. Then we put out a public our communication team gets involved. We put out social media. We tell people to look for their symptoms. That's another example of the use of this technology.
That's great. Okay, from the audience, another question. How about right here?
How are you doing? My name is Dion Whitmore, right? You spoke about the 0.5% tax, right? This upcoming year, right? I will be voting for it, right? For the future of the public health. My question is, in the event it doesn't pass, is there a plan B?
Okay. This is one of our Masters of Public Health students, correct? Yes. And he wanted to know about the 0.5% sales tax. If for some reason it doesn't pass, what's plan B?
Yeah, thanks for the question. First of all, it's not a surefire thing. It's going to pass. And so please do talk to everyone. It's hard. I just want to acknowledge that, so I'm not advocating for it. I'm not allowed to as a government official. But I want to say some of the pros and cons that are being said about it so that people here can know that. But, one of the cons, of course, is it's what you would call a regressive tax. It means that, every single person is going to have to pay a little bit more when they purchase something to support this tax, right? And it doesn't matter if you make a lot of money or if you're somebody who's, just scraping by, you're going to end up. So that's why it's a regressive tax. And that's not favorable in general for those of us who are worried about the economic security of people who don't make a lot of money, right? That said, the concern is that if we don't have this revenue, it's the people that really rely on the federally qualified health centers, the public hospitals, public health services that will lose those services. And so, so to answer your question, if it doesn't pass, what's our plan B? I want to be honest, like the amount of money that's going to be lost from the system is going to be very hard it's going to be very hard to sustain the jobs and the services without some kind of lifeline. This is one example of a lifeline. There may be others. I think the legislature is talking about, California legislature, they're debating, can they find some money somewhere to fill the gap? And, who knows what's going to happen in Washington, D.C. But H.R. 1's already passed. So that's definitely going to happen unless Congress somehow reverses it. But I don't think they will. And so there isn't a great plan B right now. I mean, we're just trying to figure out, this is a plan for June. We'll know in June if it passes or not. And if it doesn't, we're going to be rapidly thinking about a plan B, but it likely will mean cuts to services.
We're going to go to one of the online questions that was submitted before the event.
I will go and ask. Thank you for addressing health initiatives for LA 28 Olympics. You mentioned AI, so I have a question here. How should we prepare for AI's increasing presence in public health, and how is it used now?
Yeah, it's a good question. I am no expert on this at all. If anything, I'm kind of a Luddite. I'm a little scared of AI. Personally speaking for myself, I'm a little scared of it. I think that I'll just say that there are plenty of caveats that you all have probably read about AI and its risks with bias. I worry about, the replacement of employment for various roles and jobs. These are my personal opinions now, not the opinions of the department. That said, I think there are also lots of really good applications of AI. I mentioned the genomic sequencing is an example. I think that on the data side, there's a huge role for AI, and an example would be something called syndromic surveillance. So what is that? So that's a program that's nationwide and that we also have here in LA County where when patients end up in the emergency room or in the hospital, the doctors write a note and there's some coding about what their diagnosis and symptoms were. And that data is crunched and you look for trends to see if there's any kind of signal that, oh no, we're seeing a lot more asthma exacerbations over in Glendale as an example from this data that's coming in. And with AI, we're going to be able to do that even faster and better with more precision. So that's an example of an AI application that I think is very right. It's already here and it's going to get much better at helping us predict early when people are getting sick of a certain kind of way.
Thank you. Thank you for addressing that, especially technology being used now and pretty much like the grant being accessed for like, ChatGPT for us to use this platform for like school. And it's pretty much like how you mentioned, not for it to be used in a negative way, but how can we excessively use it for the help of public health? And I think it's very important, as many of us here are undergraduates, and how you mentioned the employment case. So thank you for addressing that.
I think we worry all the time about AI on the academic
Sometimes,
side.
sometimes.
That's right. I'm just curious, how many people in the room use AI? How many of you are using it right now? For assignments? Yeah, I mean, from a training point of view, we want to make sure that we like train thinkers, right? We want smart people doing public health. So we don't want to lose that by just handing that over to AI. I imagine on the workforce side, you want to make sure that you're getting very smart people, not just people capable of typing in prompts to ChatGPT or whatever.
Yeah, I mean, I think, I'm only a dabbler in this, but, there's something called agentic AI, which is intended to be like so I think of it as the next generation chatbots. I'm sure people here know a lot more of what I'm saying and probably saying this guy's saying the wrong thing, but like it's sort of this idea that, I was at a meeting at Berkeley and they were talking about having agentic AI social workers. And I was shocked. The idea that a machine could play the role of a social worker in outreach as a way of, quote, reducing costs and improving efficiency is an example that I worry about. And I might just simply be a Luddite and not understand that that's actually going to really work well. And it might, I don't know. But I think as students, learning as much as you can about what's being proposed or even being tested is really good to do. So then you can, you're going to be the next generation who's going to make decisions about how it gets used.
Picturing how you replace those people who are going door to door in your community outreach, that novel program that you're doing, which sounds great. I mean, maybe it's a little weird showing up, someone knocks on your door. That seems a little bit strange these days, but making those connections, like you can't replace it. Unless it's like some robot that rolls along. I don't know.
Yeah, I don't know. I think, you and I have a certain generation different from the other members of the panel here. And so we might like people coming to the door and talking, but, I don't know. My brother, who's only a few years younger than me, he only texts me. He doesn't pick up the phone when I call him. So I don't know.
Definitely a big different like generational wave of like community, right? We have now face-to-face communities, and now we're transitioning to like this whole technology community, right? Now they have like their whole chats in Discord, and now we're using Notion to progressing like our organization and finding these online communities. So it's definitely a big transition, but at the same time acknowledging that it's still very important to gather like we are in this room. So thank you for addressing that question.
And I think I want to add on as well, something for it to kind of just be really helpful is that tool and that guide that at the end of the day, you really can't replace the person, but how can it maybe help us or even guide us more? So thank you for talking about that. All right, we have one online question as well, and this one kind of pivots into adjustments. So again, we're very curious to know, how has the department adjusted its activities to align or not align with the current national policy?
Yeah, I mean, we're generally, we have to follow the law that we have to do. But we are resisting where we can, what we think is not science and what we think is discriminatory. And so, I would just say that if we just take the vaccine recommendations as an example, I think everyone has seen that the federal recommendations from the Federal Health Agency about the vaccine schedule has changed dramatically. The federal government has changed those recommendations, but scientists everywhere in academia and in public health have said there isn't evidence for how they've changed those recommendations. And so this was an example of, not just us in the local health department, but the entire state of California has said that we're going to create state level recommendations, and we're going to ignore and tell people not to follow the federal recommendations, which they've done. And not only that, the governor and the legislature said the state recommendations have to be used by the health insurers to reimburse for vaccinations based on the state recommendations. So that's an example of public health at the state's level saying, if you're not going to use science, federal government, we're not going to follow your lead.
Thank you so much for that. I think I also just kind of want to give a big shout out to our professors who I've always appreciated that they have kind of put in the topic that racism is a public health issue. So thank you so much for your mentioning as well as like non-discriminatory, making sure we're following that.
Let's take more questions from the audience. How about right here?
Hello, my name is Jonathan Escalante. I'm a current FPH student here. I would say one question I do have, because I feel like public health, we do try to resolve issues, right? However, I feel like we never get, or public health officials never get the credit that they're entitled to. So my question is, like, how do you put public health on the map when not many people know what public health is?
Oh, I'm going to repeat your question. That's so well phrased. So public health it doesn't seem to get a lot of credit for the work that it does. How do we flip that? How do we give some credit where public health is due?
Yeah, it's a really astute question. I would say, I'll just give you a story. I was at a birthday party 2 weeks ago, and I was telling somebody about the half-cent sales tax because I was telling them, they were like, "Oh, we read you in the paper saying that you were cutting clinics. That's terrible." And I said, "Why?" I said, "Because we've lost all this money and we're going to lose more. And by the way, some hospitals are going to close and all kinds of worse things are going to happen." And they're like, and I was like, "There is this ballot measure that you're going to get to vote on." And, and this person had the, kind of like, well, and I said, "Well, let me just give you a very concrete example, sir, about what will happen if we don't get this. There is no plan B. What's going to happen? We'll probably stop ocean water testing year round. This is what public health does. People don't really think about it, but we test the water every day, and we put out a notice to say, is it safe to be in the water or not?" This gentleman turned out to be a surfer, and he was aghast. He's like, "Oh yeah, I look at that's you guys? I'm like, "Yeah, that's us guys. You mean that's going to end?" I'm like, "Probably, because there's not much more funding left for it unless you get some other funding." So, I don't know. You're asking a really difficult question that we ask ourselves all the time. We in public health don't need the limelight. We're there every day trying to protect and to promote health. But because we don't get the limelight or need the limelight or have a way of telling the story, when things get taken away, people don't realize it, maybe until it's too late. So I don't have an answer, but it's a great question.
Can I ask a follow-up? I would love to ask a follow-up. You had also mentioned during the presentation the element of misinformation. What is your recommendation for us public health officials to be able to tackle that? I work in health education, and that's something that I'm always kind of finding myself in. And I don't want to approach it in a way where I'm like forcing people to change their mind. I want them to be open to it. So any recommendations?
Yeah, it's a great question. I'm just going to say something provocative, and it's also my personal opinion. I think we in the healthcare world and public health world sort of failed in COVID at sort of communicating science. And what do I mean by failed? Like, a lot of people understood what we were communicating, but a lot of people didn't, and they didn't trust us. Maybe they didn't like the message that you had to stay at home, or they didn't like the message you had to wear a mask. But maybe we should have delivered the message differently. And I have yet to see great new ideas from the traditional, those of us in our world, of how to communicate differently. We're all kind of befuddled by it. And I turn it back to you guys. You all communicate differently than Professor Stevens and I communicate. You want it differently, you do it differently, and you'll have a better idea of how to communicate, not only to your like-minded selves, but also to the communities that are not like-minded to you. We don't have the answer. I'm just going to say, I don't have the answer. I have yet to meet anyone who really does. And I look to your generation to help us figure out how to communicate science. How do we communicate health protection recommendations, health recommendations? I don't know.
Thank you.
All right, let's see if we have another question from the audience. Yep, all right. This is our MPH row right here. I see it.
I was just curious. My name is Naomi from measures ahead of the LA 28 Games, the Olympics, in regards to single-use plastics, maybe larger crowds gathering, what you guys were implementing?
Okay, that's right. So we've covered the World Cup a bit, but 2 years from now, we have the Olympics coming. She's asking, what sort of anticipatory work is the LA County Department of Public Health doing on environment, on disease prevention, et cetera?
Yeah, in LA 28, it's the organization that's going to mount the Olympics, and they're now beginning these meetings where they're bringing together all the various parties that have to try to help make sure the Olympics work successfully, efficiently, and safely. And we're at the table for the safely part. And our role in the Olympics we're the department that does the restaurant inspections, for example, that the letter grades that are put on each of the food businesses. So during the Olympics, there are going to be these fan fests, or actually during the World Cup, there will be these fan fests, but during the Olympics, there could be lots of mobile and temporary food. So our job is going to be to inspect them all, make sure they're following all the appropriate ways of protecting the food and the quality of the food so is not foodborne illness. That's an example. We'll be doing disease surveillance. We're doing health messaging around STD prevention and all kinds of things, heat and hydration, how to protect yourself from the heat, et cetera. But your question about sort of like climate and environmental health, like environmental protection during the Olympics, it's not something we directly work on, but like single-use plastic, and how do we prevent pollution, excess pollution during the Olympics? I know there are other county departments in partnership with us that will work on that but it's a great question. At the end of the day, a lot of this is going to depend on how well LA 28 organizes and funds all the extra work that comes with these big events. And that's being debated right now. And, there are a lot of good ideas, but we also, like, every agency needs the money to implement them, and they don't necessarily have it. And so that's also part of what we have to advocate for.
Great. Okay, I see a question over there.
Outbreaks.
A little louder.
And because I just wanted to talk about that a little bit. Is there any way that as us as undergrad, would we be able to get first-hand experience? I know it's a little harder, especially to have experience or a master's with it, but would there be any way for us to reach out to get through coverage screens?
Okay, I'm going to try and correct me if I didn't get this quite right, or you guys can jump in too. But you're looking for practical experience in some of the disease prevention work that the county does. You're wondering how to get involved in that. Okay.
Yeah, I think there's definitely going to be opportunity. And, what I think what we should probably do is have some way after this to send you guys a message about who you can contact, so that we can actually make those connections. I'm imagining that we might be able to find one of our disease investigators who wouldn't mind being shadowed in their work. Maybe we could set something like that up. But I really appreciate the question. This is what I would like you all to do. Come in, we serve everyone, including you all. And part of serving you is also having you see what we do, and so you can see if you want to be a part of it.
Let me just take a moment to brag about one of the first things that our academic health department did, our partnership did, Cal State LA and LA County Department of Public Health. We did a respiratory virus outreach campaign here on this campus, and raise your hand if you guys were a part of this. You were handing out the bookmarks. You remember this? So there were public health students getting involved in disease prevention right here on campus, working with their peers. We developed bookmarks with respiratory virus guidance right at the beginning of respiratory virus season. There was a nudge to get your flu shot from the Student Health Center, and county brought some other health educators onto campus as well. So if I could just add on to what you're saying, you can do this work with county. You can do this work with your university. So that's not a one-time event. We're going to be trying to build in more of those kinds of activities into this academic health department relationship. So I'm really glad you're interested. Come and talk to me afterward. Okay, more audience questions. What you got? Raul? Okay, I'm going to rephrase your question just slightly. He's asking, like, we have plans for 2026, but what happens if those plans for 2026 don't quite line up with what's happening in 2026? So how do you adjust to that? How do you?
Yeah, it's, as you can imagine, the initiatives, like some of the examples and many others, it takes a lot of planning, investment, and training to mount these. And as long as the funding doesn't get pulled out from underneath us, and we have experienced some of these sudden attempts by the federal government to terminate grants of ours that then the judge will stop. But leaving that sort of eventuality aside, in general, what I presented is sort of stuff we're doing, we're definitely going to do. But I think embedded in your question is suddenly there's a wildfire. And that's going to mean that we have to do a whole bunch of stuff in response to help immediately while the fire is coming down and in recovery. And that happened. It happened in last year, right? And so what did we do? We ended up reassigning lots of our staff temporarily from some of the programs I showed you to work on the wildfire response. And so we do have to, in public health, you do have to be nimble, which is embedded in your question, to something that comes up that has to be a higher priority that you didn't plan for. And that means that, we ask people to step out of their training and learn something new quickly, or put something aside for a while, try to keep it going as best you can. But now we really need your help over here in supporting Altadena and supporting the Palisades populations.
So there's probably don't have time for much here, but I'm going to take some prerogative and ask my absolute favorite question that I ask every guest that comes to Cal State East campus. We all want to leave here with something we can do. And you hinted at that about talking to people about, but if you were to give us one concrete action, us up here, the folks behind the scenes, the folks in this room, the folks online, one concrete action that we could take to try and improve health starting tomorrow, what would you ask us to do?
Yes, it's a good question, a tough one to ponder. I guess, I would say, like, I'm gonna give you two things. Like, one is like what you just said earlier about, as an academic health department, you had already mounted this one initiative that you, as an example that you gave about respiratory season. I would say being involved, like literally going and doing something, or whatever the next opportunity is, because there's nothing like doing it. There's one thing about reading about it, hearing someone drone on about it like I did tonight, but there's nothing like actually doing it, like actually doing it. And those of you that have done it and done it many times, you know what I mean. When you have somebody's grandmother in front of you and you explain something to them that they weren't quite sure about, and then they're like, they get it then, right? And then they tell you something interesting that then you take to the next person. There's nothing like that. So I would say that's a concrete thing to do. The other thing I'd say to do is just do follow through on what I said. Don't ever be shy, especially because you all are going into public health. Don't ever be shy to reach out to anyone. It doesn't matter who they are. It doesn't matter if you don't know anyone who knows that person. Cold email them. I don't know if you guys still use email, but if you do, the recipient probably does. Cold email them and ask them for their time on Zoom or Teams or in person. They're going to give it to you, and they're going to love giving it to you. And it's going to be an interesting conversation for you, if nothing else.
Well, we are reaching time. Thank you for that answer. And let me just say, concluding, thank you, Dr. Mahajan, for being here with us. Being in this space matters a whole bunch. Thank you, Jhoanna, Jocelyn, for being part of this interview panel. Thank you for the interpreters that are here tonight. I'd like to say one more tiny thank you to our underage check-in assistants, Oliver and Maggie and Henry and Maddie. Thank you for doing that. Tonight is the beginning. This is not the end. This is the beginning of our academic health department partnership. I'm really excited about what this collaboration is going to make possible, not just for the people up here, but for all of you sitting in those chairs and watching online. I hope the conversation was interesting. I bet there are more questions that you've got, and maybe you can grab folks on the way out the door. I would just like to say again, thank you to all of you for being here, helping to shape what public health is going to look like this year and in many years into the future. And please, those of you who are online, get back to your bedroom safely. And for those here in this room, drive home safely. Thank you for being here.